starting the session. We'll have a insightful discussion with Dr. Ravi and the speakers. And after 3 presentations, we will have the panel discussion followed by the discussions by audience, which Meena and Dr. Ravi will be moderating. So welcome all of you. Let's get started. Your participation today is very crucial in the fight against TB. Thank you. Over to you, Meena.
Thanks, Mona. Hello, everyone. I am Dr. Meena Putturaj. I'm the team lead for the TBPPM Learning Network, Secretariat at the Institute of Public Health, Bengaluru. Today, this is the second series of the virtual roadshow, where we try to highlight innovative TBPPM models that are implemented across India. So the idea is to inspire you all with these TBPPM models and critically reflect on whether these models can work in your settings, the feasibility and the relevance of these models for your settings. We all know that when a person is affected with TB, 2/3 of the persons affected with TB with their initial symptoms, they approach the private health sector. So it is very important that we join hands with the private health sector in TB elimination efforts. So we need innovative models to engage with private health sector. So in this webinar, we're going to highlight 3 such models. Without any further delay, I would like to invite the speakers for presenting their models. Firstly, I would like to call upon Mr. Akash De from CHAI. Akash De leads the tuberculosis program at William J. Clinton Foundation in India. He has 11 years of experience across public health, policy advisory, management consulting, and data analytics. In the past, Mr. Akash De has led the TB-free Chennai initiative in partnership with a Greater Chennai Corporation. He is also an alumnus of BITS Pilani and IIM Calcutta. We are very pleased to have you, Mr. Akash De. The stage is yours. Over to you. Please take us through the model for promoting affordable and quality TB test. Thank you. Over to you, Mr. Akash De.
Thank you very much, Dr. Meena. I would like to extend my thanks to the Institute of Public Health and also welcome and thank my fellow speakers, Dr. Ravi Kumar, and all those who have made the time to attend this meeting. I would like to present a short presentation on IPAC, which would help us track what we did and how this model works. So, yeah, so to begin, as we all know, in 2012, the challenges that we were facing were the very low use of sputum tests by private providers. Although, as Dr. Meena highlighted, a large proportion of TB patients were and still are seeking care in the private sector. The knowledge of WHO endorsed TB tests was very low amongst private providers, and there was a high reliance on inaccurate blood tests like serology, which had been then recently uh, banned for use of diagnosis of TB. In addition to this, there was a fragmented lab market. As we all know, in various nooks and crannies of India, there are hundreds and thousands of labs, and consolidating that lab market to provide quality care of a certain uniformity was looked at as severely challenging. At the same time, the biggest problem was that WHO endorsed TB tests were very expensive and their sales were limited, and it was essentially looked at as a high price, low volume market by the suppliers of these TB tests. So, what was the opportunity that we were exploring? The main opportunity was to switch providers from serology to sputum tests, and the chance to aggregate labs and organize the market in a way that the same quality of diagnostics was offered to patients both in the public as well as the private sector. And At the same time, to create demand for these tests from the patients as well as their providers. The way that we thought of doing this was to drive down prices using mass market pricing and highlighting to the suppliers that there was a lucrative and sizable market for sputum-based tests, and thus for the companies to increase their sales. Why was this of concern to us, and why were we interested in this problem? It was because the price of Gene Expert at that point was very high, and that high cost led to low uptake. Um, and because at that point of time there were alternate diagnostic choices, which I highlighted were erroneous because of recent changes in guidelines. This led to no demand for Gene Expert on labs and the low uptake of the platform, and thus low market volumes. And this circle continued. So what was IPAC? IPAC stood for Initiative for Providing Affordable and Quality TB Tests. It was a consortium of private labs, which was headed by leaders of prominent lab chains such as Metropolis, SRL Diagnostics, and Lalpak Labs. CHAI, or William J. Clinton Foundation, served as its secretariat, and the M&E and research functions were done by the by ISB as well as the University of Manitoba. Sorry, by McGill University. In addition to this, at the other end of the spectrum came the manufacturers or the distributors, prominent among whom was Separate, but also included BD, BioMiro, and Zeiss. And the idea was to offer the high burden developing country pricing or the public sector pricing to private labs, which was 50% lower than what the extant pricing was at that point of time. So where we started was that the capital investment for a Gene Expert platform before IPAC was around 50,000 rupees, and cartridges cost $50,000, and cartridges cost $34. And of liquid culture to $13. The way that this worked was that all labs were onboarded on IPAC, and they had to follow certain principles such as having quality accreditation, offering only high quality WHO endorsed TB tests, notifying patients with TB to the government health authorities, and complying with predetermined ceiling price for tests. And in return, the manufacturers or distributors would offer the cartridges at a much lower price than they offered to non-IPAC labs. And labs, by becoming part of IPAC, essentially promised to pass on these lowered prices to the patients. And the idea was that all of these market players, such as labs, distributors, and manufacturers, would be able to maintain or even increase their profits or their market positions. And the customer would also benefit because of the lower pricing. And all of this would work since the efforts that were made by IPAC as a consortium would increase the volumes that were being demanded by the market as a whole. So on the demand side, various interventions were taken by the IPAC group. The first was continued medical education seminars, essentially conferences, where large groups of providers in particular cities were made aware of the standard TB care guidelines, as well as the accurate diagnostics which were supposed to be followed. We've also adopted a pharmaceutical industry method of medical representatives uh, visiting clinics and recommending TB diagnostic tests. In addition to this, focus group discussions of opinion leaders and smaller groups of providers were implemented. And finally, at the end of the project, to ensure sustainability, a form of marketing involving digital engagement, where through a digital platform, regular articles, videos, etc., would be passed on to the providers was also tried. So what did IPAC achieve? IPAC started off with 5 labs and went on to more than 350 labs and 6,000 collection centers across India. And more than 80% of Indian districts uh, were a part of this through at least one participating collection site. The the test volumes for the uh, the tests which were part of IPAC increased substantially. Uh, almost 10 times over the period that was tracked. And finally, the price of IPAC, what we noticed was that through market signaling, even non-IPAC labs, to make sure that their client base was secured, started bringing down their prices. So when we stopped tracking prices, what we saw was that even in non-IPAC labs, the price offered for Gene Expert came very close to that which was offered by IPAC labs. So network effects also work. What IPAC couldn't achieve was covering the entire spectrum of demand in India. And although the tests which were offered through IPAC labs increased exponentially, it was nowhere close to the demand that was forecast for TB patients seeking care in the private sector. On the demand side, what was realized was that it was quite expensive to sustainably carry forward the CME and FGD form of demand generation activities. And there was insufficient interest on the part of labs to match these activities which were done through donor funding. And this level of intensive marketing was not thought of to be sustainable. At the same time, one of the ancillary objectives of IPAC, which was to make sure that labs were notifying patients which were being diagnosed in them, was not achieved to the level that was desired, and only 30% of the labs were um, only 70% of the labs were notifying, 30% were not. And finally, even though prices dropped by 30 to 50%, um, these prices continue to be high when it comes to out-of-pocket spending. And the average TB patient still feels the pinch because this is a substantial portion of the average monthly household incomes of most patients. So, in sum, although IPAC as a pilot and as a novel intervention achieved quite a lot, there is still a lot to be done in the private sector and to make sure that tests such as Gene Expert are affordable for TB patients. Thank you very much.
Thank you, Mr. Akash De. For those of you who are new to TB domain, Gene Expert is a cartridge-based nucleic acid amplification test for rapid diagnosis of TB and also for rapid antibiotic test. So there are so many delays documented for TB diagnosis from the patient side and also from the health system side. This model, what you presented, the IPACT model, is definitely very helpful to address the health system challenges in diagnosing TB. even though there are several challenges, it can be improved a lot, but still, this is a good start, I feel. Thank you very much for taking us through the model. Now, I call upon Mr. Vikash Panibatla from TBAI to present the model on Pratham, which is about involving pharmacists and rural healthcare providers in TB care. To introduce Mr. Vikas, master's degree in social work and environmental sciences. Vikas has 19 years of experience in strategic planning, organizational development, and liaison and coordination. He has vast experience in grassroots implementation of various projects. Vikas
Thank you, Doctor. Hope I'm audible.
Yes, Doctor.
Yeah. Thank you, Dr. Meena, for a nice introduction, and thank you, Dr. Mohana, for finding out it from the back, which is an old project indeed, and I thanks to Dr. Ravi Kumar for being part of the panel discussion and my fellow presenters today. So today I'm going to present about a model where we work with pharmacists and chemists and informal providers. I've got a 16 slides, but I'll try to finish it in 10 minutes. There are some animations. If there are any issues with the animations, please excuse me. This is about TBL at India. I'm not able to. Yeah. Yeah, this is me for the TB is our core work. We are working in 7 states in India, and we use a comprehensive holistic model, and we see that we engage relevant stakeholders in providing care and support to the TB people with TB. So in our experiences, which has led to the development of this project, is as it is. Yeah. Patient initially visits to a pharmacy, collects 2-3 medicines, a person who is having any sort of symptoms. If it is not reducing, they go to a rural healthcare provider, RHCP. And if it is not being it is not being dealt over there, they go to private doctor, private hospitals and private doctors, and then they get it tested there, and then at the end they come to a government facility or NTP facility where they are in a very advanced stage of diseases. This project basically tried to build this gap between the visit to the RMV, RHCP or the chemist to the private hospitals directly. The context of the present project is like we have a chemists and RHCPs who are the first point of contacts for any sort of ailments right from the beginning, including fever and cough. They could be probably people having TB-like symptoms, and the requirement over here, there's a high scope of early detection of TB among these people who are coming to these chemists and RHCPs. We preventing diagnostic delays and treatment termination. That's how the bridge between these two is been. We attempted to do it in to this Pratham project, as I was mentioning. This project was implemented from 2012 to 2017. Pratham means first. It was implemented with 9 tuberculosis units in Telangana. We started with 4 and then extended it, and state had taken up. We implemented in a mix of rural and semi-urban areas. The activities included mapping, sensitizing, training, enrolling, tracking the performance of the enrolled chemists and RMPs towards referral follow-up, and link them with the NTEP. This was funded by Lilly MDR partnership. And as I was saying, the objective is to bring about active and sustained involvement of chemists and RHCPs in the RNTCP. At that point of time, it was RNTCP. We, before starting the project, had certain questions like, Initiative might affect the chemists and medical shops business because business is their main orientation. Will this initiative help? Will they help us in this initiative? RHCPs who are who wanted to experiment or in a sense to try all sort of medicines on their patients before going to the testing. Will they link their patients to the TB care was another question which had. To what extent volunteer chemists and RHCPs will be successful in connecting people to the TB care in means to NTEP in a sense like where we wanted. Will they support or will they ensure they get tested? Will they support in the reducing in the diagnostic delays? Will the pharmacists and RNCPs support us voluntary because we did not had any honorarium concept? And why will they participate were some of the questions which we got. And in 2017, we got these answers where 270, approximately 500 chemists were involved in the program who came up and voluntarily associated with us. 400 RHCPs formed and linked their patients to the TB treatment at government facilities. Both of them together had referred around 12,000 people with TB-like symptoms and facilitated 80% of them reached for the testing, which is a huge number, I believe, and leading to around 1,300 people, which is around 14% of the total referral structure. And there was a diagnostic delay from 3 to 4 because they were directly after the initial discussion, they were sent to the NTEP clinic. And they supported us voluntary in spite of being some dropouts. And there are some intangible benefits for them as well for the participation of these in these programs. So these are some of the testimonies which we had from the beneficiaries as well as with the RCPs, beneficiaries who were referred by them. As you can see, they have convinced the person to go through, as you see the first testimony, I'm very thankful to Krishna sir. It was he who convinced me to go for testing and I was diagnosed with TB. He talks to me and verifies friendly to give the medicine. Some of them has acted as dot providers as well. I was frightened when the medical shop person told me that I might have TB. I just went for the medicines for the cough. I initially did not believe him. He took special interest and explained me. So these testimonies give us an insight into how they were quite involved in the program and how did they help us in the project. Now, what are the intangible benefits they are having? You can see a testimony from an RHCP. My patients come back and tag me for referring for TB testing. I became his family doctor. So I'm very happy for that. So what are those actually? There was an increase in the trust in the community for these people whom they have referred. They were served better. So they started coming back, which further added their business. As this particular RHCP was saying, relatives from their near family were also started visiting him for the initial ailments. They got a lot of recognition from the DTCOs and the drug control authorities for chemists. And they were, and this especially RHCPs drive or desire these, they strive for this sort of recognition they want. And finally, they get a satisfaction to some extent. These are the tangible benefits which we're helping out. These are the numbers which we are speaking. As you can see, these are the steps which we had in the project. We could see 54% of people who was mapped were sensitized and 64% of the sensitized were trained. Out of that, 64% were, I'm sorry, 64% were referring, actively referring. Actively referring means at least one person per month who is referring is considered as active. And you can see around 87% of the referred cases from the persons from the TB, from the referees for the DMCs in case of RHCPs. On an average, 21% people per month was 21 people PTS was referred by chemists, by one chemist, if you take in that sense. With respect to RHCPs, you can see 81% have gone for testing who were referred, and 14% have gone for 14% have gone for diagnosed with TB. So in a sense, and around 11 people, on an average, 11 PTS were referred by these chemists, RMPs, RHCPs in the program. So this gives us a snapshot like how did they were involved and the proper management is required in order to keep them engaged. Of course, there were some dropouts. We also tried to analyze what was this contribution in the nearest tuberculosis unit where they were working in. We see like around 5% was the contribution from the project chemists in the nearest tuberculosis units. And 3% was from the chemists, from the RHCPs in the nearest tuberculosis units. And with respect to test persons diagnosed with TB, the contribution of pharmacists was around 4% from the people who were diagnosed, and it was 3% among RHCPs who were doing that. In that sense, their contribution was though less, but it was a major contribution, and we were looking for the early identification and early diagnosis treatment. So we followed a strict mechanism where we have followed a triplicate referral slip, and all of the enrolled chemists and RHCPs were given this referrals. There were 3 copies in it. One was the main sheet, which was referred by referral slip given to PTC by chemists and RHCPs for referring them to the DMC. Once they visit to the DMC, that slip was maintained at the DMC. This slip was within the book of the RMP or the chemists who were working on, and also there was a slip which was deposited at the when the patient visits with the slip. One slip was taken up by the DMC and which was stored remains with the referred person. So we did a triangulation of all these 3 before entering into the system. One which is deposited in the DMC, one which is within the book of the RHCP or a chemist, and one which is with the facility center, so that the reporting mechanism was ensured. Apart from that, we had a database of all the chemists and RMPs who were working with us, and we also had clear marcation of the referrals from them in the TB register. In those days, TB register was being written at the thing. So coming to experience which we have gained or learnings which we have taken up from this initiative was individual commitment and interest works rather than the pressure from the associations. I won't say like they should be ignored. We need to reach with the associations as well, but the individual commitment of the chemist and RHCP has more progressing information for more work, and also on focus on the quality rather than the quantity. What I personally believe, like there will be a dropout of the people who we have trained. Taking that into the fact, not to get disheartened, and we keep motivating the people who are doing and do a follow up with them regularly and see their touch, while trying to bring someone, some of them at least, some of them who have left us. Time is precious. They really precious. So our training programs, our interactions, our meetings should be very crisp. They should be informative, and they should be straight to the point. Renew motivation. We did not try any financial motivations here, but we ensure like they get letters from the DTC or district tuberculosis officer. We saw that they get recognized in the World TB Day events or any other World Health Day events, so that their contributions are referred. And also we don't harm their business interests. In a sense, we need to a right balance needs to be ensured between the engagement and asking them to refer. We can't exactly say like you don't give any medicines if a person comes and directly refer to them because it affects their business as well. So a slight balance how we convince them so that they don't sell off too much of medicines or don't do too much of work on them, so that balance needs to be handled with them. Handle the expectations carefully. Once they get enrolled with us, they wanted the clients whom they referred to be given a VIP treatment at the testing facilities they are sent. So we need to handle that a bit clear, and we also need to coordinate with the NTEP in taking this forward. Other aspects which we tried out was a peer motivator concept, where we have selected one active RMP of a pharmacist, and we linked 5 to 6 chemists or RMPs working near to them to act as a master trainer and to act as a motivator. Such 60 people were part of project, and this was done keeping sustainability in view. And they were kept in close contact with the local NTEP so that any facilitation could be done. Sometimes we also checked out a characteristic strategy where, especially with the chemists, when the district control authorities or district drug inspector were visiting, we made an advocacy with them so that they could check what's happening about this project, or while they are checking other things, and give them appreciations or send them letters, so that if they are not doing, then ask them to refer them for the testing. We have taken up the patient perspective study to understand the effectiveness, how from the beneficiaries perspective, where 57% of the respondents reported that if the RMP was or chemist has not referred, they would have waited for 2 or 3 weeks because it was just a cough or just a fever, they would have waited it. 69% felt that information given was true, and after reaching the testing facility, they were diagnosed with things. And bridging the communication gap with the NTEP is another various crucial area, where we don't say like NTEP is quite busy in their other aspects always, and these are important contributors whom we need to work out, and ensuring that coordination between two of them is very important, and we tried out that aspect as well. In this project especially helped in early identification of PTS in initial visits to the shop, which is helping in preventing further spread of TB infection. Early referrals to NTP activities and treatment initiation, which was also helping in the diagnostic, preventing the diagnostic delays. Some of the RMPs and chemists have worked for the TB program as DOTS providers at that time. So improving the treatment and ensuring treatment completion was there. Early identification and early diagnosis and early treatment was preventing the drug-resistant tuberculosis as well. So this brings to the end of my presentation. Thank you very much. Over to you, Dr. Meena.
Yeah, thank you very much, Mr. Vikash, for presenting your model. We know that private health providers are not one homogeneous group. There are a wide variety of actors out there in the space, like the pharmacists, the diagnostic people, rural healthcare providers. So some of the actors we may not like, or in the sense they are not formally recognized in the system, but still it is important. Whether we like it or not, they are out there, they are close to the community, we have to engage with them. And I really like the point what you shared, that it's more about not just about the input or the output of the projects we do, but it is also about the processes that we pay attention to, like creating a positive environment so that building trust with these actors to efforts such as giving appreciation letter. That is very important. I really like that. Thank you very much. And I think Dr. Ravi also will have a lot of questions to you about this, but we'll wait for that. Thank you very much again. Now we move on to the third presenter. Yeah. Now we move on to the third presenter, Dr. Satish Kumar, to present the CAP TB model, which is meant for the pediatric TB population. To introduce about Dr. Satish Kumar, Dr. A. Satish Kumar currently works as country director at the Solidarity and Action Against HIV in India, which is shortly referred to as SAATHII. He has over 20 years of experience in the public health and development sector, with a specific focus on STI and HIV, AIDS, tuberculosis, and maternal and child health, and also healthcare access to LGBTIQ plus communities. He has been working in HIV projects since 2004 and presently working for the elimination of pediatric TB. We are very happy and I'm very pleased to invite you to this presentation, Dr. Satish Kumar. The stage is yours. Please take over. Thank you.
Thank you. Thank you, the TPM, the TBPPM group, Dr. Meena and the team here, and the facilitators and the master and all participants here. Good morning again. We represent SAATHII. SAATHII, can you please share the PowerPoint I'll share the bottom. This is okay. Okay. Yeah, maybe I'll start
You have
with
to
the
speak up
video.
a bit louder, Dr. Satish. It's a bit feeble.
Okay.
Yeah. Thank you. Yogin, can you play the video?
Yeah, we can play with the video first. The video explains the program in a summary, and then I will go into the presentation after that. Yeah, thank you, please.
Yogin, are you there?
Catalyzing Pediatric TB Innovations is an initiative to scale up pediatric TB care in the private sector in India through evidence generation. In partnership with the National TB Elimination Program, SAATHII implemented the project across 15 districts of Maharashtra, Andhra Pradesh and Telangana between 2018 and 2021. The project strengthened capacities of private providers on standards of pediatric TB care and improved access to quality diagnostic and treatment services. CAP TB supported the NTEP and the Indian Academy of Pediatrics in training over 700 pediatricians on updated pediatric TB guidelines. The project used 2 intervention models in all 15 districts. Under the first model, more than 3,000 private facilities providing pediatric services were mapped and engaged for NTEP activities. A mix of practitioners were covered through this model, including pediatricians, chest physicians, general physicians, and other specialists. Under the second model, additional interventions were implemented at 82 private pediatric facilities. Under both the models, patient support services were provided to children with TB. At the 82 sites implementing intensive interventions, all outpatient and inpatient attendees were screened for TB symptoms using a simple form by existing site staff who are trained on intensified case finding. These site staff first screened all children for the symptoms given on the left side of the ICF form. If a child had any of the symptoms, the doctor further evaluated them using the right side of the form and referred them for investigations if TB was suspected. CAP TB helped children with presumptive TB get free diagnostics by reimbursing the facilities for the costs of X-ray and sample collection procedures and by linking them with NAT services in the government. As soon as a sample was collected, site staff informed the CAP TB field coordinators who then picked up the sample and delivered it to the NAT centers for testing. In addition, the project linked an expert radiologist to the 82 CAP TB sites to ensure accurate interpretation of chest X-ray images. Children diagnosed with TB were linked with the NTEP for free of cost child-friendly TB drugs as per their weight. CAP TB staff then ensured timely drug refills through regular follow-up. For every child diagnosed with TB, CAP TB field coordinators undertook reverse contact tracing. They visited their homes to screen family members for TB symptoms. Those with symptoms were referred for TB evaluation. Asymptomatic family members below 6 years were referred for TB preventive treatment. Over 3 years of implementing technical support across 15 districts, CAP TB reached almost 3,000 private healthcare facilities, registered more than 900 facilities on Nikshay, trained over 700 doctors, and reported more than 2,200 pediatric TB cases. Through intensive interventions at the 82 sites, the project helped improve the uptake of chest X-ray, reduced average time taken for diagnosis and average treatment initiation time, and also linked TB cases to public sector drugs. To attain India's goal of eliminating TB by 2025, it is necessary to bridge the gap in pediatric TB care in the private sector. Let us come together to make this mission possible. TB हारेगा, देश जीतेगा.
Thank you, Ms. Mohan and the IT team for playing this, Mr. Yogin for playing this video. I'll now share the presentation. Just give me 1 second. Is the PowerPoint visible and is it audible, madam?
Yes, yes, Dr. Satish. It's clear.
Okay. Okay. Yeah, thank you. So we have seen the video which summarizes the entire experiences of this catalyzing pediatric TB innovations project. The project has been was funded by UNITAID through Elizabeth Laser Pediatric AIDS Foundation. This is a multi-country project where in 9 African countries the focus was on public sector, and in India the focus is on was on private sector. So we completed the project in 2021 and we transitioned further. And I will share the experiences a little bit more what we have seen in the video into further details. So we can see that we had 2 implementation models. In 15 districts of Andhra Pradesh, Telangana, Maharashtra, we implemented the 2 models. So the focus of the project had 2 sides. One is the across 15 districts provide district-wide technical support to the TB program. And the subset of that is evidence generation sites in 82 facilities. This was the 82 sites. Evidence generation was done in an implementation research mode, where the entire intensive intervention was done in those 82 sites. So I will explain a little bit in detail about the first model, where we worked about evidence generation. So we had 15 districts where we added sites in a phased manner from 2019 to 22, Jan 22, October 20. So that's how the scale up happened actually in the project. So when we started the project, we mapped all the private healthcare facilities in 15 districts, and we identified around 50% of them have providing pediatric services, which includes physicians, pediatricians, and other general practitioners treating children. And we assessed almost majority of them. We assessed them and identified high load pediatric sites who are willing to do sample collection and provide TB services. And we then approach them for partnerships. Out of in each district, around 10 to 15 sites we approached, and then 6 sites per district agreed for the collaboration. So out of 15 districts, we had a partnership with 82 sites. So we can see an example of a district in Ahmednagar where almost like 309 pediatric sites are there in Ahmednagar district. They are spread across the district, and we partnered with 14 sites so that the spread of these 14 sites are there in 7 talukas. 7 main talukas are covered in that project, which includes both 8 rural and 6 urban sites. So that way, in each district, we want to have the spread of sites also in both rural and urban settings. So the model was that every child who's coming to the OPD was screened, and presumptive TB children were identified, and they were then free chest X-ray and sample collection. If chest X-ray is abnormal, then sample collection was done. So it was done free of cost for the patient, and the project built in a coupon system so that on a monthly basis we reimburse the cost to the sites, and the patient sign a declaration that they have not paid for any services. So X-ray and sample collection were done free of cost, and where pediatricians needed expert radiologist support, the X-ray films were transmitted to the expert radiologist who gives the information, the report about the X-ray opinion, and the pediatrician make a decision on the X-ray opinion, and then further do sample collection. And we provided sample transportation support, and if based on the results, TB treatment was started with public sector FDCs as much as possible, and some private FDCs were also given, and we did the reverse contact test. So this was also explained in the video of how intensified case finding was done. We had left side and the right side of the ICF slip, where left side was used by the paramedic staff and the right side was confirmed by the doctor. So the doctor confirms the child as a presumptive TB, and then the investigation starts from there. So we pay, because this was done in a research mode, we have paid a nominal incentive to the paramedical staff to do screening of every child in the OPD and IPD. And because of the reimbursements, all the cases underwent immediate X-ray, which around 84% got X-ray in 1 or 2 days time. And we also, given these snippet posters kept, and so that we promoted these communication materials also for engaging private providers. We also developed the pediatric TB treatment chart, TB screening posters, and for the training we did so that everywhere these IEC materials were distributed to all the pediatric providers in 15 districts. And also we supported national TOT, state TOTs in the 3 states, further district level trainings in the 15 districts were supported. So in addition to the trainings and distribution of materials, a periodic one-to-one sensitization, on-site sensitization and visits were done by the project team to adhere to the national diagnostic algorithm and follow for identification of the sensitivity. So the summary is that throughout the project period, 11,68,760 attendees visited these 82 pediatric sites, and 72% of them were screened at the first level and identified 63% having some kind of TB-related symptoms. But the actual presumptive TB confirmed by the doctors are 3,419, because some initial symptoms of cough, fever would be there, but when you label it as a presumptive TB, the doctor has to confirm that. So we had 0.4% of them screened were presumptive TB, and 395 of them found to be positive. So we can see that the number needed to screen to identify a presumptive TB is 240, and number needed to screen to identify a pediatric TB is 2,129. So that's the number outcome which we received. And the process is, if we see, 84% were evaluated with X-ray, 50% of the presumptive TB cases were evaluated with NAT, and 96% of them were initiated on treatment, with 85% on public abuse. So related to treatment, the most important learning good part is when we partnered with pediatricians. Majority of them are pediatricians, with 1 or 2 health care pediatricians and safe physicians in this partnership. The total TB positives in that, we can see that 0 to 5 years, that is 51% of the children identified were less than 6 years. And then the rest of them are 6 to 10 years and 11 to 14 years. Because our focus was with pediatricians more to understand how to do this model. So the engaging pediatricians led to increase in case diagnosis among younger children less than 6 years. And we had equal proportion of males and female. And the diagnosed cases are microbiologically diagnosed is 20% and 80% clinically diagnosed. We typically see around 10% are microbiologically diagnosed in the kind of data we saw, but our project had 20% of the cases microbiologically diagnosed. And 99% initiated on treatment, 89% completed treatment, and we had 5% loss to follow-up and 5% deaths reported in this entire cohort. And we promoted the NTPs, FDC drugs, which are flavored ones and easily consumable, and because these are disposable tablets, which were actually promoted for the private patients also. The private doctors, pediatricians accepted these drugs and started prescribing these drugs. Even IAP has come forward to prescribe the the public FDC drugs. During IAP trainings, they actually spoken about these drugs, which also promoted the government FDC drugs. And we can see that how the proportion of the public and private FDCs changed over a period of time. So to begin with, in year 1, we had 79% were getting public FDCs, that increased to 90 or 89% over year 2 and 3. And we also try to compare what are the composition of public FDCs and private FDCs. We can see the public FDC INH rifampicin pyrazinamide combo are for 50, 75, 150, which is the standard combination as per our national guidelines, public FDC. Whereas private FDCs, if we see the combinations are variable combinations of 50, 100, 300 milligram, 75, 150, 400. So actually, these are unstandardized doses. So we have actually shared these findings with the private pediatricians to enable the importance of public FDCs, being followed up. So that advocacy helped to increase the public FDC update. And this case study has been also published in the WHO Operational Handbook on Tuberculosis. This acceptance of prescribing public FDCs and the results were actually included in the WHO Operational Handbook. So that is all about the learnings from the first model of 82 sites. Now I'll just take 2 or 3 more minutes to complete the district-wide technical support. So in these 15 districts, we try to reach to all 3,000 private facilities and then try to support them in registering in the NICSHI and almost like 7,000 presumptive cases from altogether 15 districts identified over the 3 years, and 2,225 pediatric TB cases are reported. So this was the overall reach in the 15 districts. And we did the analysis of data of NICSHI 2017 to 20 during COVID period to understand what is the pattern of pediatric TB cases reported by various type of providers. So we can see that generally pediatric TB cases are reported by pediatricians, general physicians, chest physicians, and other type of providers. So these are the four group of people who report pediatric TB. In that 60% are pediatricians, and whereas general physicians who treat children are 16%, chest physicians are 14%. In general, general physicians treat older children, whereas pediatricians treat younger children, and that is visible in the bar graph bar, where you can see the variable proportions. As the age increases, the proportion of children notified with pediatric TB notified has been declining among the pediatricians from 75% to 67% to 35%. You can see pediatricians reporting pediatric TB cases has been declining. So that shows clearly that older children are getting managed by general physicians and chest physicians. So hence, in the district approach, we try to engage all types of providers so that we can get more cases of diagnosis done. And so what we did is through this follow-up, we actually followed up with all these practitioners. And on a yearly basis, you can see that the number of sites reporting presumptive TB increased from 271 to 325. And in 2 quarters of 2021 alone, 265 facilities reported the presumptive TB. And similarly, sites reporting pediatric TB also increased from 160 to 248. And one in 6 months, 204 sites reported in 2021. And this project worked throughout the thick and thick of COVID period. And despite that COVID being there, we engaged with the pediatricians. So we continued, and the numbers actually increase happened. So that was actually a very pleasing effort from the IAP to support this activity. One more example I want to share is in one of the district, Karimnagar, when we started, it was 1% of the total TB notification was pediatric TB, and it increased to 3% by the time that we completed the project. It increased to 3% of the total TB cases. So that has happened because most of the pediatric facilities started reporting over a period of time, and so that's how it increased happened to 3%. And so from these two models, what we want to share the learning is that if we have to increase pediatric TB in private sector in a district, then we need to have two approaches. The two approaches is that the first approach is have pediatric TB hub sites with pediatrician and radiology and pathology centers partnership. We can have one combo partnerships of pediatrician, radiology and pathology centers. Or if the same one hospital has all these in-house services, bring those 3 to 5 sites at least in each district as a partnering site. At the same time, we cover all other pediatric practitioners and saturate them and link those facilities to these hub sites so that the hub sites provide these services. So if we build in such a model, and the hub sites need to have some partnership with the government. If there is a partnership, then patient will get free of cost services in these hub sites. If there is no partnership, funding is not available, then at least a non-financial MOU can be signed with these hub sites to make them agree for a fixed cost at a low cost and a fixed cost. The services can be provided. So if we have this model of a few hub sites and then saturate all other private pediatric practitioners, we can actually increase the detection of pediatric TB in the district. And so the key learnings are engage pediatricians if we want to increase the case detection 0 to 5 years. And the huge gap in India is around 0 to 5 years age. So engaging pediatricians will help to get more cases. Engaging high-load pediatric sites as hubs in every district and enable comprehensive pediatric TB service provision. Engage different types of providers to saturate pediatric TB coverage in a district. Especially ENT doctors are one more group of important doctors who treat lymph node children with lymph node swelling. And partnerships with IAP is essential for active engagement in a district. And so if this learning has to be carried forward in the current environment, when we did the project 2021, PPSAs were just beginning, and we transitioned our learning experiences with PPSAs in AP, Telangana, Maharashtra, and we shared the learnings with them, and we shared all the tools with them. However, if this has to be continued further through PPSAs and STSUs, first important thing through the state technical support units wherever they exist can do the following. Or if STSUs are not there, the state TB cell can support these activities. First is compile the list of IAP trainers who attended national, regional, and state POTs, and have all pediatric TB trainers list with the program. discuss with IAP, have partnerships built in where they identify one nodal person from each district chapter of IAP. And the roles and responsibilities of this nodal person from each district chapter could be that they can identify and recommend pediatricians from each town or city in a district for partnerships. IAP can take leadership and they can discuss with their
Dr.
member
Satisha,
pediatricians.
sorry.
Yeah,
Can you please wind up?
yeah, this is the last slide. And participate in the consultation meetings, compile the list of IAP members, and have periodic activities through IAP. Then where PPSAs are there, we can have engage PPSAs to map the pediatric facilities, provide materials, periodic follow-ups, and ensure the referrals from them. And through a CTD and a state TB cell at the state level and national level, periodic review of these 3-4 core indicators on pediatric TB in the private sector, which would help to bring in attention and focus on the pediatric TB attention. So these are some of the materials which were actually got published. And one of the important documents I want to share is CTD developed a collaborative framework for engaging RBSK, RKSK, and strengthen pediatric TB for public sector also as part as an outcome of this project. And some budgeting templates were created and states were given to put in pediatric TB budgeting for the private sector and public sector from our experience. Thank you.
Thank you, Dr. Satish. We know that TB is one of the top 10 causes for death in children universally. So we need to, and also diagnosing and treating pediatric population for TB is very challenging also because the symptoms are often very different and it is hard to obtain the specimens. Diagnostic tools have limited sensitivity, and also there are a lot of side effects for the drugs. So it's very important that from our system side, we need to put in extra energy to do and also do active case finding in pediatric population. And I see that this model, what you presented, is actually creating an environment for promoting active case finding by providing incentives to the staff, by engaging with a variety of specialist doctors who are concerned with pediatric population. This is truly innovative. Thank you very much. And also for the very engaging video. It really took us what is really happening on the ground. Thank you very much. So I would like to take this time to thank all the speakers once again. And now we have the exciting part of the webinar, which is going to be the discussion between a district TB officer and also the speakers. So the district TB officer here will have now the opportunity to reflect on these models, share his experience being a system level actor. So it would be very nice for us to learn how we felt about these models and and his thoughts. So, but before that, I would like to introduce our district TB officer from Chamarajanagar district. He is also a good friend of Institute of Public Health, Bengaluru, Dr. Ravi Kumar. Dr. Ravi Kumar has a MD in community medicine. He is a public health physician with extensive experience in public health programs and administration. Currently serving as the district TB officer in Chamarajanagar district in Karnataka state since 2022. He has a proven track record in managing and implementing healthcare initiatives for TB control. Dr. Ravi Kumar brings over 17 years of experience to the table, having previously served from the grassroots level as a medical officer in Mandya district and Taluk health officer for almost a decade in various districts of Karnataka. And presently is the DTO. We are very happy to have you here, Dr. Ravi Kumar. The floor is yours. So this is the time we would like to hear from you on what you think about these models. And if you have any critical questions to ask our speakers, we would encourage that. Thank you very much. The floor is yours, Dr. Ravi.
Thank you, Dr. Putraju, and thank you all for your participation. Also, I thank the organizers for including me in this virtual meeting or about the PPM projects that have been already implemented from a long time in different parts. And all the three presentations were really eye-openers for me. all the three, that is IP Quad and the Pratham and CAP TB. Excellent projects that have really shown the results at the field level. Because as far as my area of work where I am working now in Chamarajanagar district, it is one of the backward districts in Karnataka state. And there are many challenges in the goal of eliminating TB here, because the private sector is not so much grown like or so advanced as in all the three settings these projects have been implemented. But the way the projects have really contributed to case finding and then diagnostics and case holding, and especially in the pediatric presentation, what I observed was it has made a huge difference there. And they were all really, all the three were good. And rather than asking questions about the projects that you have done, because almost you have like in a methodical way you have gone ahead and done this project over years, and they have shown good results. Definitely the PPM models which you three have presented here are like examples where we can try to implement in other places. So there are many aspects. The private engagement is a very tough challenge in elimination of TB, especially as Dr. Veena Putraj was also telling, our private sector is it's not like uniform or standardized. It is a heterogeneous group. Like we have all types of practitioners, starting from unregistered medical practitioners are also there, what we call as quacks, and to the super specialty hospital. But there can be no comparison between them. And the cases are being missed even in the, our doctors and specialists and pediatricians, or somehow they're not diagnosing cases as per the percentage that is estimated in the TB burden. So 10% of the total TB cases have to be pediatric cases. That's what the estimates say. But in my district, it's around 3%, 3 to 4% or less than that in some areas. So across India, I think this is a problem, and pediatric TB is a real challenge, because most of the doctors, they hesitate to even subject the patients, the pediatric patients, for TB screening. And moreover, for microbiological confirmation, the sample collection is another challenge, and depending on just X-ray and clinical symptoms, many hesitate or postpone the diagnosis of TB in children. And even I was surprised when the death rate, which was presented here in the project, is showing at 5%. 5% death rate in pediatric cases is really, I think, high. Because our one of the targets for elimination of TB is reducing the death rate to 90% compared to 2015. Although it seems like it applies for general TB patients everywhere, but for pediatric cases, the 5% death, that too, the project has a structured way of testing, referring, and then also following up. And in spite of everything being given, I was a little bit aghast to know that the death rate in pediatric age group is also 5%. I just wanted to ask I think Shashi Kumar presented that. Satish Kumar.
Satish.
Yeah. What could be the reason that, have you analyzed why there is 5% death rate? What were the causes? Can you please enlighten us on that?
Oh, yes, sir. Yeah, thank you, sir. That's a very important observation. What you have pointed out. The primary reasons where people are identified and came late, where deaths have happened in the initial 2 to 4 weeks of time, and the majority of the cases were having actually the TB meningitis or abdominal TB, severe abdominal TB, or severe pleural effusion, where when they came, they were very sick, and then diagnosis happened, through various, diagnostic procedures. So majority of the children who came were actually very sick at the time of the diagnosis. So that was the primary reason here. When we interacted with the pediatricians to identify the causes, these were the primary reasons they have said, informed us, and this is what they have informed us also.
Yes, sir. Yes, sir. Okay. And one more thing, sir. Were there any DRTB cases among the pediatric group?
Yes, sir. We had around that among the total number in the study of 300 numbers, so we had only one or two only DRTB. All are drugs assisted TB from the study group. But in the programmatic mode, where we had almost like more than 2,200 cases reported in the 15 districts, it was almost like 10 to 20 cases. I remember 15 cases, I think, that were DRTB, less than that, even very less than that. So at the 15 districts over 3 years. So our districts, the reason was DRTB was very less is that the districts were not primarily urbanized except Nagpur, one district. All others are kind of a mixture of urban and rural or more of rural district. And at that time, the other PPCA projects were happening, the JEET and other projects were happening. So hence the districts which were selected and were implemented were primarily non-urban geographies. So hence the DRTB levels were very low in those geographies.
Especially as the percentage of microbiologically confirmed cases were very, comparatively, it is 20% versus 80%. Like 80% were clinically diagnosed pediatric cases.
Yes, sir.
So it is, I think it's almost always difficult to find the DRTB, diagnose the DRTB among the pediatrics, as microbiologically confirmed cases percentage is definitely less. Definitely, it is difficult also to get the samples for FLLPA or culture, and that's the reason why we may be missing cases in pediatric DRTB due to this. Anyway, it is actually a very good project. Like the way you presented, like in every district, there should be a unit wherein these cases are followed up or screened properly and counseling done. In pediatrics, the challenge is also convincing the parents. Any parent will not like to hear that his or her child is having TB and we have to give a treatment for a longer duration. And that is why most of the people, they start this shopping, they start jumping from one doctor to another doctor. And this also leads to delay in diagnosis of TB cases. And all the three projects definitely show that if there is a better PPM coordination between the program and the private sector, wherein it is bridged by these projects which are taken up by individuals or organizations or NGOs. If they take up these projects and bridge this gap, I think it will be better. As far as I have observed, we also call these private practitioners regularly for sensitizations and the facilities that are available in government sector, wherein they can coordinate with us. And that's what most of them are doing now. For example, in my own district, there are 130 registered practitioners, and our PPM coordinator is the only person who keeps interacting with them, or the next line of our NTP staff, the STS, STLS, or the DRTB supervisor, they will be interacting with them, but it is not to that extent. So what happens among the 130, we are getting references from 40. So you can just see the percentage there. So the rest of them are not referring at all. So where are the patients OPD? Even they get their significant number of OPDs. And where are the people from there, where they are being referred, we don't know. Or the patient will keep hopping from one doctor to another doctor. And somehow we are doing it. But when we look at the participation from the private sector and also the involvement and the understanding of the TB as a social disease wherein many factors influence it, and because of the stigma attached to it, with all these things, if there is an interface wherein the these PPM models can bridge that gap, which will help in taking the program and elimination of TB forward in a better way in all places. And I have been looking forward that if anybody is, like coming forward to do it in our district, I will always welcome them. And I had an interaction with IPH people where they told that they will take up some project shortly. It is definitely going to help the program at every level. The understanding of the elimination of TB through a multi-pronged approach, whether it's the pharmacies or the labs, laboratories, or the government sector, everyone has to come together along with the community, wherein people have to, make an organized effort to understand the dynamics of this TB. How with 30% of the population in our country being infected, and the incidence rate to come down, it will take a longer time because we have a large infected pool in our community. And definitely, if we diagnose the cases early and bring down the chain of transmission in a very effective way, then only I think we can proceed toward this. And all these three projects are very, I felt they were good, and such projects are always welcome, and it will help at the government or the policy implementation level through their participation. That's what I feel. And I don't have much questions. Actually, the other participants can definitely, who have seen the presentation of the projects or who have been participating in that, they can come forward and carry on the discussion.
Thank you, Dr. Ravi. This was very enriching conversation, I should say, because often I think PPM is like a marriage between public and private. Marriage works only when there is trust and there is a positive environment where everybody wins. So I think we need to create that kind of environment, which ultimately benefits the public, persons affected with TB, and also ensure achieving the public health goals. This is fantastic because this is not like a usual webinar where only the project implementers from some NGOs talk among themselves. This really, we want a dialogue to happen between the public and the private actors. So this is an excellent opportunity. And thank you very much for sharing your perspective and your experiences and for posing those very reflective questions. I also invite the speakers, if you have any thoughts, reflections, questions to ask to Dr. Ravi, most welcome. And also the audience, please use this opportunity. We have both the private health sector actors and also a representative from public health sector. It's a wonderful opportunity. Please use it and ask your questions. Yeah, speakers, any thoughts from your side?
Yeah, thank you, Dr. Meena. Thank you, Dr. Master, for your valuable opinions. I think there are a lot of practical learnings, as you rightly mentioned, sir, from these presentations. From a pediatric TB perspective, what I think Dr. Meena also asked to kind of bring out the discussions.
I think we lost Dr. Satish. Mohna, is he there? Okay. Vikas, in the meantime, I think Satish might be trying to join again. Vikas has raised his hand. Please go ahead, Vikas.
Not much, Dr. Meena, and thank you very much. And thank you, Dr. Kumar, for your impactful insights into the presentations and your zeal to know more about the projects. That reflects the commitment you have made to the elimination of TB. I have got 2 points to mention over here. Though we talk about the private sector as a major area which needs to be focused, what I personally feel is like NTEP's concentration is mostly on the registered and the qualified private providers whom we are looking out. But especially, and I really congratulate Sir, like he has been following up 100 registered RMP doctors in his way. There's a lot of there's a lot of there's a huge number of RMP doctors working over here who are the first contacts of the people, because they give house-to-house services. Their costs are very less. They are being trusted by the people over there. So that is another area which I particularly will personally feel more focus from NTEP needs to be bring in, because what requires to involve them is like, we need to recognize them. We need to give them a small amount of technical knowledge, not about the treatment, but about about TB and how to do this, because they wanted to know about many things. Of course, the RMP doctors which came to us, they wanted to know about the details of the medicines, combinations of the medicines, how to give it, what is the chemical formulations. So those they're much interested in those, but giving them some basic information in it is a much important thing. And thirdly, like a follow-up of regular follow-up from them, either using a stick or a carrot method, which I would be saying is like, you're not referring, why you're not referring, sort of thing would be something thing. But there's a huge potential at these doctors which can be tapped, which I feel, and I congratulate Dr. Ravikumar for concentrating on the RMP doctors as well. This is what I wanted to mention it. Thank you, Meena. Thank you, sir.
Thank you, Vikas. Dr. Ravi, would you like to reflect a bit on engaging with informal healthcare providers? Because there is so much controversy around it, right? Like once we engage them, they try to utilize this as an opportunity to gain recognition from the formal system. And there is also a little opposition from the registered practitioners. So how are we going to deal this politics around engaging informal healthcare providers in TB service delivery? Any thoughts from your side, Dr. Ravi?
That's a very tricky thing because see, in Karnataka there is the act, the KPMA Act, wherein they have provided an opportunity for all the registered, that is those who are having a from medical council, any medical council, like whether it is Ayurveda, Unani, or like that Ayush, all the Ayush doctors, they can definitely do the registration, and they will be in the mainstream. But the informal practitioners, as you said, where I already mentioned that there are many people who are unregistered. See, if they are unregistered and they doesn't have a valid certificate and they are practicing, it is something like they are practicing based on the trust placed in them by the public. That is in our country, all said and done, people will always listen to the word of mouth rather than anything else. So somebody says, I went to that doctor. They don't know what the doctor's qualification is or what is credentials, or they will just think, yes, I went there or I took the child there and he got well. Maybe most of the times it will be like coincidental, or maybe the first registered medical practitioner or the hospital whom our people have gone to might be, they might not have talked to them properly, or the cost effectiveness may not be not there. So many things come into practice in this health-seeking behavior of our public, which is capitalized by these people. And once we as a system try to engage them in this, as you said, they will definitely feel that they are being recognized and they are valid or legal or whatever it is. So there are a lot of things, I think, in our country which is not uniformly monitored or controlled, or the government rules varies from place to place, and some cases are there in the court, and this unregistered practitioners being in existence is a thing that we have to accept with a pinch of salt, or whatever we have to take it. Like then how to engage them? We have had a discussion in our state meetings with our officers that we are supposed to conduct trainings or sensitization for all the registered medical practitioners whose list we have. But what about these people who are unregistered or who are doing, without any board, they will be practicing. There are such people what to do. So officially, we cannot take them in. And informant incentives cannot also be given to them because they are not in our system at all. So we have to somehow find a way. That's where in some of the districts, some of my friends, till now I have not done it, but some of my friends who have done this, they have called them for a meeting. See, like just volunteers meeting, like. So you call them for a volunteers meeting, like, and you sensitize them about the TB symptoms and the facilities available, and make sure at least that the people who are going to them as presumptive TB cases are observed by them and being sent to our system or to registered medical practitioners of their liking, so that we will not miss the case. And the incentive, the notification or the informant incentive can be given to the person later in a different form. Like if we refer to a private practitioner, the incentive can be given to them and he can collect from them. So something like that, we have to make some internal arrangement wherein we don't miss the case. So in the interest of the TB patients who might be missed because of their lack of knowledge about TB or about the program that aims at elimination and bringing down the number of cases by this. So if we make them understand the whole nation is being, trying, because we have the highest burden in the world. So you should not miss referring the TB cases, or you keep treating them without referring them. Then they will come in a later stages. Anyhow, once the patient gets worse, they're definitely going to refer that. So before that only, if you find these initial symptoms, initial stages of the disease, you refer the patient to the system wherein we have a robust program, which is one of the well-structured and organized program, wherein we take care from the diagnosis till the treatment outcome with intervals of follow-ups, and also their comorbidity management. Even their social issues are being addressed in the program through Nikshay Mitra, and also this NPY, whatever incentives we give. So once they are in the system, the outcomes will be definitely better. So if we make them understand, saying that you cannot be a part of our system, but still you can help the program. That is the message where we have to stop for them. So they will definitely cooperate, because anybody who listens to the story of TB elimination will definitely get interested and start contributing, because nobody wants to hinder such processes, whatever their positions may be. So we have to make them understand the vastness of this program, and also the existing structure that is nearby, where it will help their patients. So anyway, if they are not referring the patient, and if the outcome is bad, whatever happens to the patient, and in the future they may turn back to them and I ask, why you didn't refer us, or why you kept treating in spite of knowing that we had TB, because they will have high regard for them. So even their reputation will go down. So if we talk to them like that, in a way where we are not pulling them into we are not telling them or indicating to them that we are pulling them into our system, but they are a part of the community, wherein they can just, like, as volunteers, they can send the patients. This is where I think we can work on that. Anything else, like at the government level, definitely we can't take them in any way, as far as I know. And it has been successful in some of the districts of my friends, DTOs, who are doing like that, and we have discussed it. So till now, I have not done that in my district, and right now we are having a lot of issues with the KPM registration, and most of the unregistered have stopped our clinics being stopped. And still they will start practicing at some places, at their homes or some places, secluded places. They will, because the people go in search of them. So we cannot leave them alone. Whatever their percentage may be, over the time, it is better if we involve them in the system, in the process. That's what I feel.
Yeah. Excellent points, sir. Thank you for sharing your practical experiences, practical challenges in engaging with informal health sector. Yeah, it's very quite challenging to engage in this informal healthcare ecosystem, but as you said, we should also not forget them and their potential for contribution for TB service delivery. Points well taken, Dr. Ravi. I
Right.
think we have reached to the end of the webinar. I request the audience, if you have any questions, I give a minute. Please raise your hands. If not, then we'll have to close this webinar. Yeah, any questions from you, audience? It looks like the audience is so quiet. Yeah. Anybody, please feel free to unmute your mic and ask the question.
Yeah, this is for Vikas. Because you mentioned that you will there is a balance between for the chemist to ensure their business is not gone. How is that balance maintained? I didn't get like how to refer the medicines which is not required.
No. That's a quite important question which you told, and I fully agree with the strategy which is saying of involving them, rather not marking them as private providers or something, at least consider them as community volunteers or community provider, community engagement sort of thing, so that the huge patients going there can be trapped up. And coming to your question, Dr. Mona, like what we said is like, we did not ask him to stop giving him the medicines because the person has come to him for the medicines. It is his business. We asked him, or we sensitized him, if someone is asking you for medicine, please give it for 1 day and immediately speak to him with respect to the TB and TB related symptoms, and do a referral immediately. If he is coming for the second time, please don't give him, and also speak to him and call our community coordinator who can help you out in making the patient. That's what I mean to say. If you further go and say, no, you don't give him any medicine initially and then only refer, the response would be very lukewarm. Please give a medicine. It is just what he's giving is a paracetamol tablet initially. If I'm coming for a TB, or if I'm coming for a fever or cough, certain things, it's a small medication. So give it for 1 day and immediately ask him, and also keep a track of that person or something which we keep. So which we told them, and that's what I mean to say as a delicate balance, which I say is not completely good strategy or a good option to work in, but keep him motivated to keep in, because if you say like you don't give at all, you immediately refer sort of things, then the response would be definitely uh, gone in that sense. That's what I mean to say, the balance between the business and the things. Not too much, that's a delicate issue to be dealt with, and more cautiously and carefully we need to speak to them.
Yeah, thank you
Hope I
very
have
much.
answered your question. Thank
Yeah, but if it's just paracetamol, it's okay. If
Yeah.
he has prescribed some antibiotic and he comes after few days, then it should be problematic.
This was mostly with the chemist itself, and with RHCPs, we spoke them, you don't give any antibiotics in the initial stage. You just give a paracetamol and take your fees, and then refer to the patient to the respective DMCs. After this project, we have implemented another full-scale RMP project, where we also tried up with an mobile application for RMP doctors for easy referral and tracking of the patients whom they have referred. For RMPs, we told them not to give any, refer any antibiotics, which we did, and most of them has agreed as well. Thank you.
Thank you.
Thank you, Mr. Vikas. Aishat, please come in with your question. Aishat?
Yes, ma'am. I want to ask with Dr. Akash to question two.
Yes,
Hello,
please.
is I'm audible? Actually, you already mentioned in the slide that gene expert. Hello, gene expert test were. Hello, is
You
I
are
audible?
audible.
Okay. So my question is that what can be done in IPAC to make gene expert and other high quality tests more affordable for patients? It's already mentioned it's unaffordable, right? So what can be done?
So, one of the things that we are going to do in the coming few weeks and months is to make sure that the uh, CBNAT prices, which have been going down over the last few years in the public sector, and
Okay.
and have fallen by around 50% further since 2018, are also reflected in the private sector, so that whatever rates the government is procuring at are also those which are available in the private sector.
Okay, thank you.
Yes, Nivedya, please come in.
Yeah, thank you for this opportunity. So my question is that it was said that IPAC couldn't achieve entire coverage or expected coverage. So within short time span, which areas could be leveraged, or which areas we could focus to improve the coverage in an immediate way? Hello?
Yes.
Ravi.
So the problem with coverage was that the private lab network is extremely fragmented, and there are many small and medium-sized labs which are not a part of bigger networks. So what we had done was to look at the bigger lab chains which have presence across India and which handle most of the volumes. And in doing so, we were able to cover around 80% of the um, CBNAT prescribing labs in the country at that point of time. So the approach for any new geography should be the same, in which the bigger labs are engaged with first, and then if resources allow them to also bring in the smaller labs.
Okay, okay. And one more thing, I would like to know which all states have that TB alert in their activity, which all states have that project. Like you mentioned 7 states, Vigas.
Yeah, hi Nivedya. This project was implemented only in Telangana, but we are working in 7 states across India with other components of TBL.
Oh, it is other components, right? Okay,
Yes.
okay.
Okay, thank you everyone. We have come to the end of the webinar. Very fantastic, enriching discussions we had. Thank you once again to all the speakers, and our special thanks to District TB Officer, Dr. Ravi Kumar, for making this webinar a grand success. So this conversations, we want to keep it going. So this is not the end of the dialogue. So once in every 2 months, we organize such webinars where we try to highlight the models in TBPPM and bring in different stakeholders, and also with a creative format for the conversations to happen. So this is not the end of the story. So please keep an eye for our notification and call information on the next episode of the virtual roadshow. Thank you once again, everyone. Have a great day.
Thank you.
Thank
Bye.
you. Thank you all.
Thank you
Thank
very
you all.
much.
Thank you.
Thank you. Thank you.